You're welcome to the reproductive health segment. And I must thank you for your text messages and for keeping this part segment of the program alive. And because without your input, probably we would have stopped this. Today we're going to be discussing what we call assisted reproductive techniques. We're going to go through the gamut of trying to explain to you what assisted reproductive techniques mean. You know, the whole essence of this program is to demystify assisted reproductive techniques by giving people the necessary knowledge so that they can understand what this is all about. So I'll start by trying to define what assisted reproductive techniques or assisted reproductive technology means. These are a variety of laboratory methods that are used to unite egg and sperm with the purpose of increasing the chances of conception in the treatment cycle. So this is usually used for people who are facing the challenge of infertility and they find it difficult to conceive. For any method to belong to this group, it must have three characteristics. There must be a way to superovulate or to produce more than the normal one egg that a woman produces in a cycle. There must be a way of sperm preparation, and then there must be a way of uniting the egg and the sperm. Depending on how complex these procedures are, then we can talk about the three prototypes of assisted reproductive technology. So the most basic form is what we call intrauterine insemination, or IUI. What this involves is that, just I told you there must be three characteristics. It involves producing more than one egg, but this we give very mild drugs in order for the woman to just produce about 2-3 eggs. And then we prepare the sperm in the laboratory. And then the way we unite the sperm and the egg is not very, very high tech. What I mean by this is this. We monitor the woman until about the time she's about to ovulate. Then we inject this specially prepared sperm into the endometrial cavity or into the uterus. Now, one thing I must let you know is that naturally sperm does not go into the uterus. So you cannot put an unprepared sample of sperm into the uterus. That can cause a lot of problems. So the sperm needs to be prepared, and that's where the training comes in intrauterine insemination. Like I said, it's the most basic form. From there, we now look, because that has very limited usage. For you to be able to use intrauterine insemination, that means the sperm count must be okay. It means the tubes must be okay. And therefore, if you know what causes infertility in this part of the world, the two commonest problems are sperm problems and tubal problems. So not very many people can use intrauterine insemination. And that's why the next step, which is more complex than intrauterine insemination, is what we call IVF, or in vitro fertilization. Now, this is like a generic term because other things spin from it. But let me say that in vitro fertilization, like I said, the meaning is fertilization outside the body. This includes 5 steps. The drugs that we give or medication, the retrieval of the eggs, fertilization of the eggs, then we do the transfer of the fertilized egg back into the woman's body, and then we support what we have transferred. So let's take it along that line. So the drugs, we usually use about 4 groups of drugs in IVF. The first drug does what we call downregulation. What this means is that we make the woman to stop ovulating. That is the downregulation bit of it. Like, we want to be able to take control of the woman's cycle. Don't forget the reason why we are giving the drugs, that we want to make more than one egg, superovulation. So once we have done that, we have succeeded in doing that, then the next group of drugs are the drugs that actually stimulate the woman to produce more eggs, or stimulation drugs. Many names there's so many proprietary names, I don't really want to name any. But there's stimulation drugs. And then once we have formed the eggs, then we give what we call a trigger injection, which is that ripens the eggs that we have produced. Once we have given this trigger injection, then we must bring out the eggs, which is I told you, there are 5 stages. The 3rd stage of bringing out the eggs. Now, from the day that you're going to bring out the eggs, the 4th drug you must start applying that one, which is the drug that supports or the one that maintains a pregnancy if anyone ensues. Don't forget that we have stopped the woman from producing our hormones, so we need to support the pregnancy. So we start this from the day that after we have brought out the eggs. Now, to go to the bringing out the eggs, we don't operate on anybody to bring out eggs. This is a very simple method, using a scan through the vagina. You can see the eggs through the scan, and there's a special needle that is attached to the scanner, and you can just bring out the eggs. That takes about 10-15 minutes, and you are through. The woman rests for another 1 hour or so, and she's ready to go home. So basically, IVF is an outpatient procedure. Now, on the day that we're going to bring out the eggs, we also ask for the sperm. So we now have the sperm, we have the eggs. Fertilization can be done in the laboratory. Don't forget, in vitro fertilization means fertilization outside the body. So we do the fertilization outside the body. Now, how we do this fertilization depends on the sperm count. What are the parameters? If the sperm count is optimal, then we just do what we call conventional IVF. But if the sperm count is bad, then we do what we call ICSI, or intracytoplasmic sperm injection. I'm going to, in a minute, I'll explain what that means. Now, once we have the embryo, that is the fertilized egg, then we now, depends on the center from day 2 to day 5, we do the transfer back into the woman. Because the best place for the embryo actually is the uterus. So we replace back, and then we now support. Don't forget, I said we started the drugs for the support right from the day that will pick up the egg. So we continue on the support for about 2 weeks, and the woman does a pregnancy test to know whether we are successful or not. Now, the other thing that I said is the ICSI or ICSI, which is intracytoplasmic sperm injection. This is usually used when the sperm count is bad, especially when the sperm count is less than 10 million. Then ICSI might just be the proper method to use. And this involves selecting one sperm cell and injecting it into one egg. That's, I'm sure you've seen it a few weeks ago on the program, where I'm sure we're still going to show it again as time goes on. And then, so that's what ICSI is all about. So the difference between IVF and ICSI is just the method of fertilization. The steps, the processes are the same. To the patient, actually, there's no difference. But the only difference is how we achieve fertilization in the laboratory. So that's just the difference between IVF and ICSI, which is quite different from intrauterine insemination or IUI. Remember, I told you that IUI is the most basic form of treatment or assisted reproduction. Now, for us, for anybody to be able to do assisted reproduction, there's some things, there's some investigations that need to be done. Or if you like, there's some tests that we need to do. Now, we usually do 4 basic tests. We do the semen analysis for the man. You know, don't forget that will help us also to know whether we're doing IVF or ICSI. We do hormone assay for the woman to be able to see what is her egg stock at that point in time, what is the situation with the eggs, or whether she's ovulating. What we do, it depends on what you want to do. We do day 2 to day 5 or menstruating hormone assay when we want to see what the egg stock is. And then we do day 21 or day 23 hormone assay if we want to see whether the woman is ovulating or not. But of course, to us as reproductive endocrinologists, we are more concerned about the egg stock than ovulation, because we can almost always make ovulation to happen. Then we also do the test for the uterus and the fallopian tubes, what we call HSG or hysterosalpingogram. And then we do infectious screening. We screen for HIV, hepatitis, syphilis in both the man and the woman. So these are the tests that we do for screening. After doing this test, we'll be able to tell what precisely to do for the couple. For instance, from this, you can see whether the woman can use her eggs or she cannot use her eggs. Of course, that we also come into, we talk about later on. Next week, we continue with this discussion, and we're going to be looking at the other tests that we might need to do before doing our assisted reproduction. Thank you very much for listening. I'll see you next week.